Hi everybody, my name is Lauren Leggett. I'm the Medical Director of Education here at SWORBHP, and I'm here today to give you a pre-course for your 2019 mandatory CME. This year's overarching topic is pediatrics, and this particular pre-course module is regarding a special subset of that population, the newly born and neonate. Before we go any further, I want to make sure I give credit to Dr. Joelle D'Onofrio. She's a pediatric emergency medicine physician and medical director down in San Diego, California. I was lucky enough a couple years ago to get to work with her during my fellowship, and luckier still to hear her give a presentation on this very topic at this past year's NIMSB conference. Because our overarching topic this past year is pediatrics, she graciously agreed to share some of her slides with us for this presentation. So thank you so much for that, Joelle. Without any further ado, here is your pre-course module on the newly born versus neonate, from water breather to air breather. Following this presentation, a paramedic will be able to define the newly born versus neonate, understand differences in physiology between these two populations, and apply the medical directives based on these physiological differences. Starting with definitions, in the most recent update of the Ontario-based Hospital Group, or OBEG, companion document in May of 2018, there was a clarification with regards to how to direct resuscitation in a neonate. In order to help guide these complex resuscitations, a definition subcategory of neonates was introduced. The following table is a crop directly from that OBEG companion document. A neonate was specified as those less than 30 days, but for the purpose of resuscitation, between 24 hours and 30 days old. A newly born was defined as those less than 24 hours old. The major change in resuscitation between these two age groups is when to initiate chest compressions and the FiO2 to be provided. In those older than 24 hours, CPR is indicated immediately if the heart rate is 0 and is not delayed to warm, dry, and stimulate like it is for those newly born, less than 24 hours. If the heart rate is between 0 and 59 in the neonate greater than 24 hours old, you start with positive pressure ventilation with room air for 30 seconds. Then move on, as you would per the normal NRP algorithm, to CPR with 100% FiO2 following these 30 seconds, if no success. So why does it matter how we resuscitate the newly delivered? Well, let's look at the physiology to answer this question. Before being delivered, the unborn infant or fetus has a circulatory system that is wired completely differently from that of a baby after birth. So much so, they're like little aliens. They breathe water, not air. While a baby after birth acquires life-giving oxygen from its lungs, a fetus receives oxygen from its mother through the placenta, completely bypassing the lungs because they are immersed in amniotic fluid and do not play a role in oxygen exchange. The newly born has wildly different physiology. Let's take a peek. We will not take a super deep dive into the physiology, but here is a quick overview of the differences in the fetal circulation system. 1. Oxygenated blood, seen as red in the diagram, travels from the placenta, on the bottom left of your screen there, from the placenta to the fetus's heart by way of the umbilical vein. Oxygenated blood flows directly into the right atrium. 2. Within the heart, there is an opening in the atrial septum connecting the right and left atria, called the foramen ovale, or FO, as is listed in this diagram. Note that the right ventricle also receives deoxygenated blood from the inferior vena cava, or IVC, as in the postnatal heart. However, the fetal heart preferentially shunts the oxygenated blood from the umbilical vein to the foramen ovale. This allows most of the oxygenated blood from the right atrium to flow directly into the left atrium instead of to the right ventricle, therefore bypassing the lungs, which are full of fluid. From the left atrium, the oxygenated blood is pumped into the left ventricle, then into the aorta, which carries the blood with the highest oxygen content to the brain. The remainder of the blood then continues through the aorta and to the rest of the body. 3. Another feature within the fetal heart that differs from the postnatal heart is the presence of the ductus arteriosus, or DA, in this diagram. This vessel connects the pulmonary artery and the aorta. Similar to the foramen ovale, which shunts oxygenated blood to the left atria, the ductus arteriosus shunts deoxygenated blood into the descending aorta. This causes mixing with oxygenated blood from the left side of the heart, but allows blood with the highest oxygen content to be pumped preferentially to the brain, while the lower body tissues receive less oxygenated blood. Deoxygenated blood from the fetal tissues is then returned to the mother's placenta via the umbilical arteries to be reoxygenated. This is seen in the bottom left, and this is the fourth major difference. So here is a diagram showing the fetal heart on your screen left and the postnatal heart on your screen right. So you can see how the prenatal heart has a lot of mixing going on and not a distinct deoxygenated and oxygenated side like we have with the postnatal heart. Again, we're not doing a super deep dive into the physiology and anatomical differences. We'll just leave it there for now. So what causes this change in anatomy and physiology to go from an alien-like water breather to an air breather? Well, those babies' first breaths. The first few breaths the newly born neonate takes causes a myriad of changes. Oxygen causes a decrease in blood flow resistance to the lungs themselves. The lungs are drained by this breathing, as well as their fluid is resorbed from the lungs. There's also increased vascular resistance in the blood vessels, specifically the left-hand side. So this causes the foramen ovale that connects that right and left atrium to become functionally inept, as the right side becomes a lower pressure system than the left, so blood doesn't flow from right to left. The ductus arteriosus closes functionally within the first few hours of life, also due to the increased pressure in the pulmonary artery, as well as other triggers including a decrease in hormone progesterone. It closes anatomically within a couple months as well, but functionally the first few hours. So let's go over those differences again. So starting with 1, the umbilical vein that delivers oxygen is now gone. 2, the foramen ovale that connects the right and left atrium is functionally inept, as the increased pressure on the left-hand side prevents blood from flowing right to left, and eventually closes. 3, the ductus arteriosus normally closes soon after birth, which is triggered by breathing, and blood in the pulmonary artery goes to the lungs for oxygenation. 4, the umbilical artery that previously carried deoxygenated blood is now gone. So what a newly born neonate needs is to breathe. What a neonate who has already gone through these changes, so those greater than 24 hours old, is a different type of resuscitation, more similar to the resuscitation we are used to. So let's see how that is applied in our medical directives. The newly born, less than 24 hours, needs to breathe to initiate these anatomical and physiological changes. So the resuscitation starts just stimulating them to breathe on their own. So you start with the first 30 seconds of providing warmth, positioning and clearing the airway, and drying, stimulating, and repositioning the newly born. If that is unsuccessful and their heart rate is less than 100, you start positive pressure ventilations to breathe for them. If still unsuccessful at the next 30-second mark, they're still not breathing, and their heart rate is less than 60, then you continue positive pressure ventilation, now with 100% FiO2, and initiate CPR. The neonate greater than 24 hours old has already taken its first breath and has initiated the anatomic and physiologic changes discussed earlier. Therefore, their resuscitation starts with CPR with 100% FiO2 if their heart rate is 0. If their heart rate is greater than 0, but less than 60, you start with positive pressure ventilation with room air. You perform this, per the algorithm, for 30 seconds, and if after this the heart rate is still not greater than or equal to 60, then you move on down your algorithm to CPR with 100% FiO2 and continue on the algorithm from here. Concluding this presentation, you should now be able to define the newly born versus the neonate, so those less than 24 hours old versus those between 24 hours and 30 days old, understand the physiological differences between these two populations, how fetal circulation is completely different as water breathers, and with the first few breaths become air breathers, and be able to apply the neonatal resuscitation medical directive. A newly born less than 24 hours, initiation of the NRP is with stimulating and assisting with breathing prior to CPR. A neonate greater than 24 hours who has already initiated these changes has resuscitation that starts with CPR if the heart rate is 0, and with positive pressure ventilation on room air if the heart rate is between 0 and 59, continuing on with the NRP from that point. If you have any questions regarding this module, any of the pre-course, any of the 2019 CME material whatsoever, or really anything regarding educational content, I'm happy to answer questions at any time. Here is my email. And again, any questions, anytime, please let me know. So thank you so much for joining us. And we do have a couple more pearls on this special population, the neonate. It's topic content that's outside of the pre-course, but some tips nonetheless, so feel free to listen on for just a couple more. So this is what we're going to go over. Super brief, just a couple tips. So starting with the APGAR. Here is the AHA's NRP algorithm. Although the font is small, APGAR doesn't fit into this algorithm. Similarly, here is your NRP under the medical directive. The APGAR also does not appear here. The reason being, the APGAR is not a resuscitation measurement for the pre-hospital world. It is a standardized measure for those born in the hospital or with the midwife in a controlled setting. It helps them know how the baby is doing over time. But it doesn't guide how you or when you start your resuscitation. The questions that you need to ask as to whether or not resuscitation is required are the following. Is the baby full term? Is the baby crying or breathing? And does the baby have good muscle tone? If the answer is no to any of these questions, be prepared to start with neonatal resuscitation. Not the APGAR. Now that you've decided you need to start resuscitation with warm, dry, and stimulate, there's only really 3 simple questions that guide your management. So in 30-second segments, you ask yourself, is the baby breathing? Is the heart rate greater than or equal to 100? And is the heart rate greater than or equal to 60? Now that doesn't sound so complex, does it? So let's walk through the steps of the NRP algorithm one at a time. You start with 30 seconds of warm, dry, and stimulate. If after this, the heart rate is still less than 100, you move on to adding positive pressure ventilation with room air. If following this, the heart rate is still less than 60, you now add chest compressions with 100% FiO2. If after 30 seconds of this management and you're an ACP medic, the heart rate is still less than 60, now under your ACP scope, you add epinephrine. If at any point the heart rate becomes greater than or equal to 60, you stop the compressions and you stop 100% FiO2. If at any point the heart rate becomes greater than or equal to 100 and the newly born has a good respiratory effort, you now stop the BVM. So remember, the only thing you have to measure is the baby breathing, is the heart rate greater than or equal to 60, and is the heart rate greater than or equal to 100. So hopefully you found these extra pearls helpful in your management of these complex resuscitations. And again, thank you very much for listening to this presentation and for staying tuned with this extra material. Thanks so much, guys. Take care.